Hi, everybody. This is Dr. Dana Gibbs. Tonight we're going to do part 2 of this little thyroid mini series, Lunch and Learn. And our topic for tonight is going to be about levothyroxine and the kind of people that really don't seem to get great results with levothyroxine because it happens probably 15% of the time. Of course, a lot higher in my practice because I really don't see people unless they're unsatisfied with their ordinary treatment. So lots higher in my practice. Anyway, so I'm ready to get started. So I'm going to go ahead and share screen. This is going to be great. Okay. Here we go. All right. So the title of tonight's Lunch and Learn, or today's Lunch and Learn, I should say, is When Levothyroxine Doesn't Work, Subclinical Hypothyroidism, Hashimoto's Disease, and Other Conditions. And I am Dr. Dana Gibbs. I'm a board-certified ear, nose, and throat surgeon with a fellowship in allergy, and I'm also an expert in Hashimoto's disease and other hormone-related topics. I have been treating thyroid and allergy in my practice for over 20 years. And as my knowledge grew along those lines, I started helping patients with non-surgical thyroid disease, Hashimoto's, and then other hormone imbalances as well. So I now exclusively work treating people who need help with their thyroid, adrenal, sex hormones, and other endocrine problems for whom the standard thyroid and hormone treatments have not been effective. All right, so levothyroxine is the second or third most often filled prescription in the US as recently as 2 years ago. It was written 89 million times in 2021. And depending on who you read, 23 million Americans are hypothyroid. But even this is controversial because recent studies now show that seasonal variation in TSH may be one of the causes of subclinical hypothyroidism. And the authors postulate that as many as 90% of the patients who've been given levothyroxine should not be taking thyroid replacement, and that what they in fact have is seasonal affective disorder. They also suggest that levothyroxine has no benefit in patients who initiate treatment when their TSH value, is under 7. Now, I agree with them for the most part, but not for the reason that they postulate. It's because in subclinical hypothyroidism, the problem isn't usually not enough T4. As a matter of fact, that's the definition of subclinical hypothyroidism, is that the T4 is normal. All right, so many people who are treated with levothyroxine are not fully restored to normal and are often quite dissatisfied with their results. And remember, T3 is the active form of thyroid hormone, and what actually stimulates your metabolism, your tissue growth, your brain function, etc. And most of the T3 the body needs to function needs to be converted from T4 to T3 in whatever body cells need it, which is basically all of them. And a significant proportion of patients with hypothyroid symptoms have problems converting T4 to T3, and their disease process is less about the dysfunctional production of thyroid hormone than it is about conversion. So today we're going to discuss these patients who have thyroid symptoms and are put on levothyroxine and told that everything looks great, but they still feel bad. So in the last session, we went over these 3 patterns of thyroid results that are seen in symptomatic patients. And the first one is, again, classic hypothyroidism, where the TSH is elevated, and it can be really elevated, like 100 to 150. This is the regular hypothyroidism. And T4 will be low, and then the T3 will also be low in these folks. And low T4 tends to vary a little bit based on what the reference lab is. I've seen 0.67 as the low of free T4. I've seen 0.82 now as the low limit of T4. So it got changed a few years back, and it may have been a political thing, and not actually based on patient data, but it's hard to know. And this is what eventually happens to a Hashimoto's patient, for example, when their gland becomes totally replaced by scar tissue. This also includes, of course, people who've been treated with I-131 radiation or thyroidectomy or with external beam radiation or chemo that has seriously damaged their thyroid. Okay, the other two types are our focus for today. So first one being low T3 with T4 either in the reference range and with normal or only mildly elevated TSH. These are your subclinical hypothyroidism patients. Many of these are never treated or even completely worked up because the current accepted way to test for hypothyroidism involves TSH followed up with a reflex free T4 immunoassay only if the TSH is abnormal. And not only are there problems with TSH not being an accurate way to determine the functional thyroid status, as we discussed in the last part of this series, but there are also inaccuracy problems with the commonly used T4, free T4 immunoassay. And in normal T4, when a patient has normal T4 and really has symptoms, it is suggested that it's a good idea to repeat the hormone test with an alternative test called a GC mass spec, which can more accurately show that more accurately show that the immunoassay test is going to be sometimes falsely too high by as much as 30%. And this happens more often if the patient's T4 or their T3, for example, is on the low end of the spectrum. All right, so our final type that we talked about is this issue with elevated reverse T3. And, most people don't even think to test reverse T3. If they've even heard of reverse T3, they think it's an inactive metabolite and they don't know what to do with it. But this is a third and, in my opinion, very important subset of hypothyroidism because these people can be very symptomatic. And their T3 can be low or on the low end of the range, and their T4 can be normal, and their TSH can be normal. And this can be an actual or a functional inadequacy in the T3 hormone action in the body. So I want to really start off here with a case study of a patient that I saw that came in on levothyroxine. And this lady came to me at age 31. She had been diagnosed many years before with Hashimoto's by somebody smart. And at the time of her initial visit, she had a normal TSH and free T4, but she was symptomatic on her 112 micrograms of morning Synthroid. She had had 3 confirmed, maybe 4 first trimester miscarriages in the past couple years. She had obvious symptoms. She was fatigued, she was cold, her hands and feet were cold, she was tired in the morning, even after an adequate night's sleep, gas and bloating, constipation, reduced libido, dry skin. Adrenal issues were also suggested by some other symptoms, such as orthostatic lightheadedness and salt cravings. She was already on a gluten-free diet, and we can talk at the end about why that may be important. She did that actually because her dad had been diagnosed celiac, and because she did it and noticed that she actually felt better. Her BMI was 19.6, so obviously not overweight. And these adrenal issues cause these two symptoms because somebody who has low adrenal function will not adequately produce aldosterone, and they will start to get symptomatic from that. All right, so before we even drew her labs, I made a couple of initial recommendations, and I asked her to take a supplement called the neonatal bovine adrenal glandular that mitigates adrenal symptoms. I also asked her to divide her T4 pill in half and take half in the morning and half 12 hours later for 2 weeks. And the reason we asked them to do that is because it kind of blunts the highs and lows that you get when you only take it every 24 hours. Now, the half-life of T4 is longer than that of T3, maybe 3 to 4 days, but you still get a high bump right in the 3 hours or so after you take the dose, and then it tapers down as much as 30 to 40%. So taking it twice a day, half as much twice a day, kind of blunts that high-low that you get by doing that. And sometimes, not often, but sometimes that's the only thing you have to do to get somebody feeling better. The reason that high T4 is a problem is because this is one of the reasons why Hashimoto's and other patients will end up with a really elevated reverse T3, because when your body senses that high T4, it will ramp up the production of deiodinase type 3 and the production of reverse T3 to guard against that thyrotoxicosis. All right, the other reason that we do this Q12 dosing is so that we can get an accurate mid-dose reading. And you do Q12, and then you divide that time interval in 6, and then you send them to the lab 6 hours later. Most endocrinologists like a trough level drawn in the morning before they take their meds. This unfortunately becomes, instead of 24 hours, it becomes 27 or 28 hours sometimes. And it unfortunately completely misses the high peak levels or overdosing that occurs in the first couple of hours after the once-a-day dosing. So we have them do this, and then we wait a couple of weeks before testing so that we can get this nice stabilized mid-dose reading on her thyroid levels. And when I look at these, if you look at the reference ranges, the only thing that was not within the reference ranges on her was the reverse T3. So her TSH was 0.66, free T4 1.66, free T3 2.9, total T3 87, reverse T3 36.1. And then her ratio of total T3 divided by reverse T3 is 2.4. Whereas my feeling about desirable is the ideal mean desirable is 12 plus or minus 2. So let's look at that a little bit more. So this ideal range that I put here is for somebody who is on treatment. Remember, the reference ranges are way broader than this, and my ideal ranges are pretty tight and pretty narrow. So for her T4, remember, T4 is the storage form of thyroid. And so depending on circumstances, your body will make it into either T3 or reverse T3. And the only way you get high reverse T3 is by making it from T4. So her T4 being at the upper end of the normal range is clearly not helping her because way too much of it is getting made into reverse T3. So the ideal for T4 tends to be down at the bottom end of the reference range. And this is particularly for somebody who is on thyroid replacement. So for the T3, free T3, generally my treatment goal is going to be in the middle to upper third of the reference range. Hers is quite low in the reference range. Low goes down to 2.2 in some labs, sometimes 2.0. Her 2.9 gives us lots of room to move this upwards and get her feeling better and still be well within the normal range. I do not push people high out of the normal range for T3. Total T3. We talked about this last time a little bit. The reason to test total T3 is mainly that we need it to compare to the reverse T3. Don't really need it on its own. And the reason for this is, okay, so thyroid hormones do circulate in your blood bound to several different proteins, not just the thyroid binding globulin. And because in my modern lab, I can order free hormone or total hormone levels for T4 and for T3, because those proteins vary so much from month to month, or from situation to situation. For example, the relative estrogen status is one that really causes it to vary a lot. Those total numbers have a really broad normal range that aren't super useful on their own. However, I do know that this total T3 down at 87 is not really good. It's not doing her much good. But the only reverse T3 test that's available is the total reverse T3, because free reverse T3 would be below the limit of detection for any of the tests that we have available today. So because it's bound to the exact same proteins as total T3, I can use this as an apples to apples comparison and get a really, really good idea about where somebody's hormone status is. So when I look at 36.1, I look at that and I know she's not going to be good on this ratio, even before I do the calculation, just because, above about 16, people just don't feel that well. They also don't feel well below 8. So really 8 is the absolute lowest limit I would like to see on a reverse T3. So when you compare these, total T3 divided by reverse T3, what you're looking for is a number somewhere around 10, possibly a little bit above 10. And using this ratio is really based on clinical observation of myself and many other docs who use that based on, starting with the fact that that's the normal ratio of reverse T3 that's naturally present in normal human thyroid glands compared to T3. It's that 1 to 10 ratio. So her ratio at 2.4 is really off, really low. So not only is her T3 absolute low, her reverse T3 is really elevated. So it's no wonder that she feels terrible. So here's the thing. I do see functional medicine practitioners trying to compare free T3 directly with reverse T3. And I do not agree with this practice, and I don't think there's any accuracy in doing so. You could do some kind of fancy calculation to avoid ordering the total T3, but then you have to know albumin, the thyroid binding globulin, some other proteins, and it would still only be a calculated estimate. So the ratio is exact because these two numbers, total T3, reverse T3, bind the exact same proteins, and you're getting that nice apples to apples comparison. Now, TSH. When you check TSH on somebody who is not taking thyroid medicine, it feels okay for me for their TSH to be as high as 2 or maybe even 2.5, as long as everything else looks fine. Once they're on treatment, it doesn't actually matter if the patient has somewhat low-ish TSH, as long as their hormone levels are not high out of the normal range. Strangely, I see all the time people with their TSH in the 3+ range, but also taking statins for their elevated cholesterol, when the cause of their high cholesterol is their inadequate thyroid function. All right, I do not measure T3 resin uptake, free thyroxine index, or total T4. I don't need these. This patient has previously been found to have Hashimoto's disease and elevated antibodies, so I'm not repeating those regularly. Now, in somebody who has never had those tests, I would do that test I would test TPO antibody, thyroglobulin antibody, and then either TSH receptor antibody if their TSH is down, or thyroid stimulating immunoglobulin is another and fancier test for the antibodies that cause Graves' disease. So you can test those as well, particularly in somebody who has suppressed TSH and high thyroid numbers, then you would definitely want to do that. And there is a whole other panel of labs that I test because hypothyroidism typically is not existing in hormone bubble isolation. There's a whole panel of other tests. For example, I'm going to include a fasting early morning ACTH and cortisol, for example. All right, so this lady is getting a lot of T4, but not making it into T3. And that's typical for Hashimoto's. It is suppressing her TSH, though. So she's been told she's fine, though clearly she's not. And the next step was that we decided to, and she agreed, to replace some of her T4 with T3. And you can use an equivalency. You can say that 5 micrograms of T3 or liothyronine is equal to 25 micrograms of levothyroxine or LT4. A few studies that have been done showed 3 to 1. We're not doing exactly that here, but pretty close. So we're taking her from 112 down to 100. And how I do this is I prescribe a whole lot of 25 microgram tablets. So she's getting 2 25s in the morning, 2 25s in the afternoon. And then the T3, unfortunately, only comes in 5 micrograms. So she's going to have to cut these in half. So 2.5 micrograms in the morning, 2.5 in the afternoon. And this is not morning and bedtime. This is morning and 12 hours later. Or sometimes I will have the patients do morning and 10 hours later or 9 hours later, because a lot of them will have this afternoon slump, and they feel better if they take it a little bit earlier. Whereas if they take it right around bedtime, they're going to wake up at midnight going, oh, I'm awake. Okay. Not a great thing to do that. So her T4 goes down first to 100, and then the second week down to 75, and then down to 50, and then down to 37, as the T3 goes gradually up a little bit at a time. Now, it can be taken closer to food than a lot of people think. Soy is really the main food item that impairs the absorption of T3, despite what pharmacists tell the patients about not eating near their thyroid meds. I have them take it with a sip of water when they first wake up in the morning. They can have their coffee within 20 to 30 minutes. I like them to take it before dinner. At least 30 minutes before dinner is preferable, but I do tell them, look, if you forgot to take it and you already put the first bite of food in your mouth, just take the pill. You don't want to wait until 10 p.m. when it's been 2 hours after your meal and then take this pill. Liothyronine comes in 5 microgram and also 25 microgram. So I've not found the usefulness of the 25 microgram tablets for somebody who's just starting out. And I've never seen anybody needing more than a total of 30 micrograms in a day. And most people level out between 15 to 20. So you're going to have to continue breaking these. They're not scored, so a good pill cutter is going to be necessary for your patients. While the patients are titrated up, they are instructed to get in touch with any adverse effect and go back down to the dose that they were taking the week before when they were feeling fine or when they were feeling the same. So sometimes the escalation will need to be half as fast as what I've got shown here. So it would be 2.5 and none, and then 2.5 and 2.5, and then 5 and 2.5, and so on. So it might actually take them 8 weeks to get up to this high of a dose. Generally, I'm not going to let a patient go 8 weeks before I retest them again. If they're tolerating it that poorly, they're probably going to stop at maybe 7.5 plus 7.5 or even less than that. And frequently, you know, if you're taking it unevenly, the larger dose is given in the morning, but we are breaking in half and dividing the T4 and the T3. All right, so this lady, after 2 weeks on the T4 of 25 plus 12.5, and that's the morning and the afternoon dose, and then the T3 10 plus 10, she was feeling much better. So about 5 weeks in, and her period had come on time. So we sent her back to the lab. She did do the 6 hours after her 12-hour or her Q12-hour dosing regimen, and her TSH had come down a little. Free T4 was down to 0.59. This is too low. Free T3, 4.2, total T3, 152, her reverse T3, 10.3. So this is much, much better. Her ratio is 14.8. It had been 2.4. People will generally notice irregular periods that become regular. Their energy should increase. Sleep will become easier, more regular. Extreme cold symptoms will start to subside. They may start noticing some new little short hair, tufty hair growth, or they may actually go into telogen effluvium and lose a bunch of long hairs as they start growing the new hair. Anyway, so here's what it looks like graphed out. Free T4. Like I said, this is lower than I like to see. I think 0.6 is the absolute bottom of this. Her ratio dramatically better. Her free T3, high end of the normal range. Her TSH, right at the bottom end of the normal range. And her free T4 being too low, it turned out she had gotten pregnant. Haha. So, and you know, this is not the first time this has happened to me, so we'll talk about that in a sec. During pregnancy, thyroid binding globulin and sex hormone binding globulin, for that matter, goes way up, and it can drop the free thyroid hormone levels by as much as 30%, necessitating a higher level of replacement until after delivery, when the sex hormone binding and thyroid binding globulins come back down. So for 9 months, she was on 75 micrograms of T4, and then also we kept her at the same amount of T3. She delivered a healthy boy, full term, carried this pregnancy to term. Most people that you treat are not going to get pregnant in the first 6 weeks, but it has happened more than once in my practice that previously infertile women were able to conceive and carry to term. And more commonly, they're going to notice, like I said, that their periods become regular first, but it is crucial to inquire when you start this treatment about a patient's desire to become pregnant or not. Many of these folks will have gotten very complacent about alternative forms of birth control, and accidents do make people. So after her pregnancy, her need for T4 dropped down considerably to half of what she required when she was pregnant. So it was actually back to our originally predicted amount of 25 plus 12.5. And ultimately, after a series of tests, we settled out with her at 25 plus 25 of T4, and T3 a little bit higher at 12.5 micrograms plus 10 microgram. And her labs stabilized with her T3 reverse T3 ratio at 11.4, free T3 0.8, TSH 0.71, and her free T3 at 4.1. And she has continued to feel well, and now she has 2 healthy babies. So in her case, I cannot particularly say that she had subclinical hypothyroidism because I didn't see her before she was treated, but this scenario is repeated over and over and over in subclinical hypothyroidism. All right, so let's talk about that a little bit. So causes of subclinical hypothyroidism, the definition of which is TSH below 10 and above 4.5 and a normal free T4. This is super common. It affects up to 10% of adults in the US, and maybe it does have something to do with seasonal affective disorder. But anyway, my personal definition is if a patient has clear symptoms that suggest hypothyroidism and above their TSH is above 2.5, and they have an abnormal T3 RT3 ratio or a free T3 below 3, I will try a treatment trial with them. Causes, the most common one is Hashimoto's disease. Hashimoto's is autoimmune thyroiditis, and it is present in as many as 15% of Americans having some degree of that. Their hormone levels fluctuate from totally normal in the early disease and when it's quiescent to hyperthyroid to about 50% of the time frank hypothyroidism to total thyroid failure. But at some points in there, and sometimes for a long time, they will exist within this definition of subclinical hypothyroidism. If their disease goes quiescent, or if we cause it by taking out their non-cancerous thyroid nodules, and now they have less thyroid tissue to make thyroid hormone than they actually need. If they don't achieve remission, the fluctuating hormone levels and progressive damage to the thyroid gland is the ultimate result. So that's by far the most common reason for hypothyroidism in general, but also subclinical. There are already now 2 different polymorphisms that have been identified that decrease the ability to produce T3 in patients, particularly in the presence of exogenous T4. These are not rare polymorphisms. Approximately 16% of people of British descent will have these. And a lot of them don't actually show or don't really actually come to light until somebody well-meaning treats these people with T4 and it makes them feel worse. There are several medications that will cause people to stop making T3 and preferentially make reverse T3. Amiodarone, beta blockers, some checkpoint inhibitors, steroids, and epinephrine. Not that people are going around shooting up epinephrine, but that if you have bouts of hypoglycemia, you are naturally getting epinephrine, and that can actually cause you to make more reverse T3. Iron deficiency is another reason. And then stress is the other really, really biggie. And I've listed several different kinds of stress that do these things. The reason I'm going over this again is that a lot of these are reversible. Disrupted or inadequate sleep, over-exercising is common to see in these patients, and this raises their cortisol. Calorie restriction, same thing, psychological stress, hypothermia, and then severe illness, toxins, and cancers. So high ACTH and cortisol levels actually suppress TSH, even in the face of low normal hormone levels, particularly T3, but also T4. But elevated cortisol also increases the activity of this deiodinase type 3, and it increases the production of reverse T3, which, as we discussed last time, blocks the activity of T3 in the cytosol, in the nucleus, leading to symptoms of low thyroid, even in the presence of normal TSH, normal T4, and sometimes even normal T3. So even without an actual gene abnormality or damage to your thyroid, you can have subclinical hypothyroidism induced in the body by various forms of stress and metabolic disease without anything actually wrong with the thyroid gland itself at all. And so what are the effects of subclinical hypothyroidism? Well, I mean, many of these are asymptomatic, or it's possible that the symptoms are subtle enough that even the patient doesn't actually realize what's going on. Now, I've seen patients with executive function defects that were severe enough that I thought they actually had early dementia that totally resolved once I took them through this treatment protocol. And that was their only recognized symptom, or I recognized it. They didn't even recognize it. In addition to the symptoms that we discussed last time, there are some others that are really rarely associated with thyroid problems in the absence of other obvious hypothyroid symptoms, but that have a lot higher incidence documented in people with mildly elevated TSH. Those are coronary artery disease events, fatal and non-fatal heart attacks, CHF, fatal strokes, elevated cholesterol, elevated small LDL, because when you have less T3, you don't clear, your liver doesn't clear small LDL particles, depression, and then the decreased attention span, the executive function defects, and then diastolic hypertension, meaning a narrowed pulse pressure in hypothyroidism. And it's really interesting that the death rate is actually higher, mortality relative to people with normal TSH. Death rate is increased, mortality rates increased. And it is interesting to me that with careful questioning, these patients are very likely to be symptomatic, even with T3 that falls into the admittedly very broad normal range. Why is this? Levothyroxine gives poor results to at least 16% of the patients who are doing it, who treat hypothyroidism in general, despite, and especially this tends to be the case in people with mildly elevated TSH and normal T4. Why is this? Well, there were some rat studies that were done, and they studied combo therapy versus combo therapy with T4 and T3 versus monotherapy with T4. And you can watch the markers of euthyroidism, such as the serum cholesterol levels, the mitochondrial content, enzymatic effects in the skeletal muscle and liver, better approximate normal in patients in study specimens that are given the combination therapy than those that are given T4 alone. Likewise, the pattern of T3 responsive genes in the brain of the rats was more similar in the combination therapy than it was in the T4 only. There are human studies that have been done as well. T4 treated patients have on average, 10% lower free T3 levels than comparable controls with similar TSH levels, and below normal in 15%. And that's even with normalized TSH. This was especially true in people that they tested that were afflicted with the THR92 ALA DIO2 single nucleotide polymorphism. And in other crossover studies that were done, as many as 48% of the patients who were treated preferred combination therapy with T4 plus T3. And this was with this was a meta-analysis. This was a whole lot of random protocols that added T3, not just ones that are really optimized the way I do. So some of them, they just put everybody on the same dose of T3. And it's like, whoa, okay, they're not even checking to see what their levels are. And this number is much higher in the patients with the subclinical hypothyroidism. So the bottom line here is that measuring TSH in somebody who's already taken levothyroxine or any kind of T4 doesn't tell you anything about how much T3 the person has. They frequently will feel even worse on the T4 than they did on no treatment. And the higher the dose, the more that's true in these patients with subclinical hypothyroidism. And they have poorer outcomes when treated with levothyroxine for the reasons that we discussed last week. If you didn't get a chance to listen, this info is key. You've got availability of the replay, so I would recommend that you go back and listen to that again. But anyway, 2 reasons. One is the failure to achieve normal serum or tissue T3 levels outside the hypothalamus. And then the second one is the levothyroxine that they're given more strongly converts to reverse T3 that further blocks the action of the T3 that they do have. And that's exactly what happened in our case study patient. She had both of those problems. So it's no wonder that if T4 is the only acceptable treatment option for subclinical hypothyroidism, that specialists might actually recommend a wait and see, give nothing treatment plan, and just wait until they're sick enough that the T4 actually does something to them. Anyway, too much T4 or fluctuations in T4 push down T3 levels. Twice a day listen to me, twice a day dosing can really help. And I generally will start with that. I'll start splitting the dose of levothyroxine for the 2 weeks that we talked about. These patients are angry. Non-physician healthcare providers are taking advantage of them, charging them exorbitant prices for health coaching and then not replacing their thyroid hormone. Now, there are some things that can be done. We'll talk about that at the end to reverse some of these things, particularly the stress-related causes of the subclinical hypothyroidism. But they aren't able to give them thyroid replacement. They aren't able to interpret the test the way a physician can. They are not able to think out of the box or think critically about the results that they get when they do labs. They'll do a shotgun, thousands of dollars worth of labs, and then tell them to go on a diet. And it's like, oh, really? That's what you paid for? Oh my God. Anyway, after you split their thyroid dose, the next thing you need to do is carefully assess their adrenal function and manage that if needed. If they're showing signs of adrenal insufficiency, like salt craving, fainting, or orthostatic dizziness, that's a whole nother talk. And if people are interested, then I will go ahead and put that one together too. When you do your tests, you want to do them in a very regimented way, with this mid-dose preferred, and you need to do all 5 of the tests that I mentioned. You generally want to do a medication change and then test them again within 4 to 6 weeks after each medication test. You want to pick a time of day to do your test. I really like the mid-dose, not the peak or the trough. It may be a little bit inconvenient for the patient, but lunchtime is okay with most patients once they understand the need for this consistent timing. You need to not forget to stop their biotin supplement. Biotin interferes with immunoassays and will cause the numerator to go way up. So if your patient is on more than 400 micrograms of biotin a day, their tests are not going to be accurate. All right, so we talked about these ideals a little bit last time, and I'm going to go over that again because I think it's super important. So free T4, this is the storage form of thyroid. We talked a little bit about what would happen if you have too much. So ideal tends to be bottom of the reference range. And I find that people are pretty consistently too high when they come in treated, on levothyroxine alone. Or sometimes when they have been treated with natural desiccated thyroid as well, because a lot of the people who treat patients with NDT are not following their labs or not following all their labs to see what they're getting. Anyway, too low on the free T4 is also not good. I don't like to see 0.6. 0.7 is okay. 0.8 is kind of really where I like to, is my sweet spot that I like. T4 does have some direct effects and people feel very bad without any T4 at all. So free T3 needs to be pretty tight, upper half to upper quarter of the reference range. It has direct, so upper quarter of the reference range. And then total T3, I don't terribly look at the total number, but I don't like to see it be above about 155. I definitely don't like to see it below 100. So I'm getting just a ballpark gestalt when I see numbers that are off of that. Reverse T3, because we're comparing it directly to the total T3, it's an apples to apples comparison, and we want that ratio to be between 10 and 14. If you're treating teens, I've seen 17, 18, and they do just fine there. The ratio tends to be very consistent across a wide range of total T3 and thyroid binding globulin levels. The absolute level of reverse T3 should not be below 8. You do need some reverse T3 for some genomic and non-genomic effects, which we don't have time to go into today. And I did mention, if you check TSH in somebody who is not on treatment, it's okay for it to be as high as 2, as long as everything else looks fine. But on treatment, 1 or less is going to be much better. They can be low normal. They can be frankly low. If you get them below 0.4, then other doctors who only check TSH are going to start trying to put your patient on T4 and mess everything up. So you don't want to have their TSH down below 0.4 if you can help it. Now, being an ENT and dealing with people with thyroid nodules all the time, I would actually push some people. I would suppress them down into the very, very low TSH, but that's either they've had thyroid cancer and we're looking to make sure they don't have a recurrence, or they have a nodule that is growing and we're trying to suppress that growth so that they don't need to have surgery. T4 alone is never helpful for that. I have actually even sometimes given people methimazole to force down their T4 and TSH numbers along with replacing T3. That is also a topic for another day, and typically something I would do in a patient who had Graves' disease but did not want to do surgery or I-131. So if you get numbers that you don't like the first time they come in, you want to start replacing their levothyroxine with tiny doses of liothyronine and twice a day. So it's a 5-to-1 ratio. So for every 5 micrograms of T4 you take away, you give 1 microgram of T3. You increase by 5 micrograms a week, or even 2.5 micrograms per week in people who are super sensitive. To get that dose, you will have to cut a 5 microgram pill in half. You want to generally increase the amount of the T3 until you're giving them about a 70-30 ratio. So 70 T4, 30% T3. The generic liothyronine pills are impossible to cut. They shatter. So there are specific brands of generics that I do recommend. So you want to try to get the absolute hormone levels into the ranges that I talked about in the previous slide. And then when the reverse T3 starts to fall below normal, then you can go back to adding a little bit of T4. It will generally be a lot less than you think. If they are on none at all, I would start them with 12.5 micrograms. That's a half of a 25 Levoxyl twice a day. When you're changing things on people's dosing, even when you're adding a supplement or something, you never want to change more than one thing in any given week, just because then they can't tell what's making a difference for them. So if they're on the Levo or something that, levothyroxine that is, or some combination of something that's not giving them good relief, the first thing you want to do is divide the dose every 12 hours, like we talked about. And I typically do tell people to start doing this. Like, so if I do an introductory call with a patient, I'll say, hey, before you even come get your labs, start taking your thyroid this way. Here's why. And then we can go ahead and get the labs quickly once they come into my program. So I prefer the mid-dose test exactly 6 hours after the morning dose. And on the day before they're testing, I like them to take the evening dose exactly 12 hours before they're going to take the morning dose. Now, patients will misinterpret these instructions. They'll say, oh, well, I'm going to go to the lab at 10, so I'm going to get up at 4 a.m. and take my morning dose. No, that is not the point of this. The point of this is take the medicine at the regular morning time, the same time you always take it, and then go to the lab 6 hours later. Yeah, people get some weird ideas. And so you really want to be very specific, and you want to ask them, what time did you take the pill the night before? What time did you take the pill that morning? What time did you go to the lab? What time did they actually stick you? Because that 6 hours, because the half-life of levothyroxine is short, you really, if you wait 30 minutes, you're going to get a significant difference in their level. The next thing is stop and retest before you get to what you think their ideal level of liothyronine is going to be. You might want to even stop before we didn't stop until 20 on my lady because she didn't have any side effects. But if they start getting side effects, you have to do kind of a specific protocol, and I'll show you that in just a second. And we need to talk a little bit about why it's so important to take your T4 every 12 hours too. And I get this question all the time. Well, don't people need more thyroid in the morning? Maybe a little, but most of the increased energy that healthy people have in the morning is due to the circadian nature of their cortisol secretion. And that fluctuation really matters as far as pushing up their reverse T3. So I get somebody in who's not getting ideal results. I'll question them again. I'll be like, oh yeah, I went back to taking all my levothyroxine in the morning. Well, the reverse T3 has gone back up, and then we have to fight it back down again. So really, really, the ideal physiologic way to do it would be to take 24 tiny pills once every hour, or a pump like an insulin pump. TID is even better than BID. And so really, you may have to spend some time explaining this to the patient. And once the reverse T3 has gone up and the T3 is down, it can take weeks for the reverse T3 signaling to calm down and let it drop. I tend to have to gradually switch people over, and maybe, adding an extra 5 micrograms of liothyronine every time they come in for a while. All right, so what are the alternatives to levothyroxine? Well, okay, so better forms of levothyroxine are a real thing. Brand Synthroid is better than the generic levothyroxines. There is one other one that I think is acceptable. It's called Levoxyl. And other than those two, I have seen T4 be contaminated with reverse T3. And so if you get a patient who is on a generic and they come in with really bad results and you can't get it straightened out, the next thing to try is switching them to Tyrosint or Synthroid and just see what happens. Another alternative might be to switch to a natural desiccated thyroid, such as NP thyroid or Amar thyroid. There's also a new one of those called Adthyza. It still needs to be taken twice a day. It still has T3 and T4 in it. When I do my calculations, I don't look at the milligrams of the natural desiccated thyroid. I calculated out saying, okay, well, that's 38 micrograms of T4 and 9 micrograms of T3. And that's a 4-to-1 ratio. And for some people, it's great. And for other people, they need something different than 80-20. They need 70-30. They need 60-40. You can use some natural desiccated and then add extra T3. I've had very good luck doing that. But it's generally going to be a really small amount of extra synthetic T3 if you do that. And the calculations get a little complex. You can change your T3 dosing regimen 2-3 times a day. That will level out that afternoon slump. So they take them 6:30, 2:30, 10:30. Do not use compounded sustained release T3 or a combination pill. One, you cannot vary them independently. And two, the sustained release, the resins they use just drops the total amount of T3 that the person is getting, and does not give you ideal results. When you do your informed consent with these patients, you have to remind them, this is not the standard of care treatment. This is an experimental type treatment. You don't have to say the word experimental, but you can say this is an integrative treatment. You need to review the symptoms of excessive thyroid with them. Remembering that there is a dose response curve. The symptoms of low thyroid and of high thyroid are often exactly the same. So as you build the dose, first nothing seems to happen, then they get better, and then if they take too much, they will feel worse. Generally, patients on too much thyroid become either tired or wired, and the symptoms of too little and too much are exactly the same at times. The final thing that you can do is what the nutritionists and the coaches and the naturopaths do, which is address the underlying cause. That works when insulin resistance and stress are the only things that are causing the thyroid imbalance. It may, diet-wise, it may help their autoimmune inflammation. And there are some things that can be done about autoimmune inflammation. There's a lot of research going on right now. There are studies that show that inositol plus folate can help. Biologics like rituximab are under study. Adding selenium, there are studies that show that that work. There are other people that say it doesn't work. There are very small studies showing that decent luck with mesenchymal stem cell treatment. That is very, very experimental, and not, I don't think, allowed in the United States at all. There are some metformin trials that show reductions in thyroglobulin antibody. And then you can recommend a patient for surgery. You can remove the source of the inflammation by getting rid of the thyroid gland. And unfortunately, then you're stuck with somebody who is frankly hypothyroid and quite brittle. And that leaves them needing lifelong thyroid replacement with no endogenous thyroid. You can treat their insulin resistance and they will feel better on a low, quick release carb type diet, a Mediterranean diet, a keto diet, removing gluten, soy, and sugary foods, and high processed seed oils, vegetable oils. Some other things that will worsen Hashimoto's in particular: pregnancy, high doses of iodine, vitamin D deficiency, leaky gut, endocrine disruptors like plastics, PCBs, and then high doses of lithium or interferon or IL-2 blockers will all possibly trigger autoimmune inflammation. And if you can get those gone, then a lot of times the patients will get better, maybe not completely well if damage has already been done. But anyway, so we talked a little bit about some T3 dosing concerns. I found one study that said the half-life of T3 is 20 hours. I've also heard 6 hours. either way, once daily dosing leaves you part of the day overdosed and part of the day deficient as your levels vary by over 50%. There are a couple of reasons to move your T3 up really slowly. So at first, when somebody's really been deficient for a while, their receptors are really upregulated, and a tiny, tiny amount goes a really long way. This starts to normalize as things go along in the treatment. And then the second reasons for problems with T3 are really only peripherally related to the thyroid. So they're typically either stimulants or transient bouts of low blood sugar. So these patients will have been drinking pots of coffee or other caffeine beverages just to stay awake. And if you give them T3, it activates their metabolism, and now they can actually feel the effects of the caffeine, and the T3 gets blamed. If you retest them, you will find that the T3 number is well within your normal range. Another reason would be adrenal insufficiency. Two things can be going on there. One is that if somebody is severely adrenal insufficient, then speeding up their metabolism will make those symptoms worse. Muscle weakness, complete inability to tolerate stress, and they will blame it on the T3. Their aldosterone may go down, and they may start fainting. And then the second issue is that because high cortisol raises insulin levels, then if you speed up their metabolism, then they're going to consume the blood sugar faster. They'll have high insulin and then low blood sugar, which spikes adrenaline. And adrenaline obviously is going to make them shaky, sweaty, and they're going to blame the T3. If they are eating the simple sugars and starchy carbs, it magnifies the effect of that bad diet. One final co-founder is if the patients have impaired mitochondrial function because of, say, chemotherapy, or because they're on a lot of psychoactive medications that are known to damage mitochondrial function, then they may not tolerate a relative increase in T3. And when you're starting people on liothyronine, you really need to calculate their max initial dose, and it should be no more than 0.28 micrograms per kilo per day, and then go up to maybe 20% less than that calculated maximum before you retest them, because going too high is not a good thing. So the our T3 ratio really does help eliminate guesswork, particularly along with the free T3 calculation or free T3 number. It gives you less reliance on TSH as an indicator of whether their thyroid is functioning. It allows us to ignore those variations in the level of the binding protein somewhat by comparing total values of T3 and a reverse T3. And you got to remember that the T4 that they're getting that's not cleared by alternative pathways is going to be deiodinated either into T3 or reverse T3. So that ratio is really our best indicator of thyroid hormone signaling. And if you treat this way, you can get excellent results with conditions like chronic fatigue syndrome, demyelinating diseases. Those are animal studies, depression, dementia-related behavior problems, heart failure, low metabolism, toxin-induced euthyroid 6 syndrome. And these tests are not expensive. The 5 tests that I tend to run in my practice, if a patient opts for a cash price that I pay and then mark up to them, the cost to the patient is only $45 for this entire 5-test panel. So in summary, reverse T3 is an inhibitory hormone. Thyroid hormone doses really ought to be divided at least every 12 hours. Therapeutic blood levels should be tested according to peak and trough fluctuations, preferably at mid-dose, and that ratio of T3 RT3 is your friend. Some people need to take T3, not everybody, but a lot of people need to take T3 with or without T4 for their best clinical results. So it is really possible to achieve some truly remarkable results applying these simple suggestions that I have offered for you today. And I am ready to take questions, and I actually have a few because I want to talk a little bit about some troubleshooting that can happen. So if a patient is intolerant of the T3, and we talked about reasons why that could be the case. The first thing to do, and the easiest thing to do, is to ask them to halve their caffeine every week that they raise the dose of cytomel or liathionine. The second one is to really look at their diet and see, are they eating a lot of processed carbs, and try pushing that towards a lower carb diet, a more whole food diet, to see if that helps. Check their history for stimulants like ADHD medications is another stimulant that people will be on. I've seen people need to decrease those by half when you get their thyroid doses into the ideal range. Estradiol, if these people are perimenopausal and you give them T3, it not only raises their thyroid binding globulin, it raises their sex hormone binding globulin, which decreases their estradiol and will give them night sweats and hot flashes. And they will blame the T3. And so you have to possibly look. This is one of the tests that I always test ahead of time, and then you can check it again and see, have you dropped their free estrogen levels? Have you raised their sex hormone binding globulin levels to the point where they need more estrogen? So the other things is the T3 and the T4 quality. I mean, if they're doing everything right and you get the labs and their T3 is high normal and their T4 is where you want it, low end of normal range, and their reverse T3 is really, really high, there may be a problem with the quality of the medications that they're being given, including some brands that are actually, frankly, contaminated with reverse T3, and switching them to the brand names will definitely help. Another thing you can do is, as I mentioned earlier, is you can switch to using an LCMS test to see how much of a difference you get. Sometimes you'll be shocked how much different there is. It's like, okay, the immunoassay said that their free T3 was 3.8 and turns out it was 2.8. And it's like, dude, that's 30% less. That's the difference between great and terrible. So sometimes you need to do that to see what's going on. You may need to slow the advancement protocol. If they're really, really having trouble tolerating the T3, you may need to slow that protocol down and raise them at 2.5 micrograms per week as you're raising it up. The other thing you want to do is you want to be really obsessively accurate about the timing of the lab. So when I send the patient to the lab, I send them an email with a little form on it. And the form says, at the time of your labs, you were taking T4, this many micrograms in the morning and this many micrograms in the afternoon. And T3, this many micrograms in the morning and this many micrograms at the afternoon. At what time in the morning? At what time in the afternoon? And your blood was drawn at how many hours after your morning dose? And your night before dose was given how many hours before your morning dose? And have them fill that out every time, because that information really does help you interpret whether those labs are absolutely accurate or whether there is something wrong with your protocol, or if the patient had to wait an extra hour because the lab was full, or because they did one of these sillinesses where they took the pill at 4 a.m. like I was talking about. It's really important to limit the number of refills that you give people, because sometimes patients will go, well, if a little is good, then a lot is better. I'm going to go higher than the recommended interval dose before I go back to see the doctor. They are very, very likely to have problems if they do this. If they experience side effects, the first thing you want to do is you want to drop them back 1 week, one step, and do that for a couple of days and then call. A lot of patients, when they get a side effect, their natural instinct is to just, oh my God, I have to stop it all. No. Back 1 week and then call and re-review the history and make sure they're not having one of these other non-T3 related reasons why they're having these side effects. And then have them do that lower dose for 2 weeks and then come back with the testing. Sometimes their result will be like buying a Coke, where say the Coke costs 60 cents. If you're old as I am, you might remember that. So you put 45 cents in, you get nothing. 55 cents, you get nothing. 60 cents, boom, you get a Coke out. Sometimes their symptoms are like that, where they don't get any better, boom, don't get any better, don't get any better, boom, all of a sudden they're feeling better. Sometimes it's more like climbing a ladder, where every step you go up, they get a little bit better, a little bit better. You want to recheck them always at somewhat less than that estimated maximum dose. And you really do want to suspect that they are on too much if their symptoms are consistently worse 2 to 3 hours after they take the medication. And you always want to check all the blood levels again. If they're doing great and their blood levels look great, you can send them off after, if there's no changes, you can send them off for 6 months. If you make a change, really 4 to 6 weeks, maybe the longest 8 weeks, if the change seems to be working really, really well, before you have them come back. You want to limit the amount of refills, because people are people and they will not want to come back for their follow-up appointments. And then the last thing that I want to address is, what about treating Hashimoto's? People all the time are claiming, oh, I can cure Hashimoto's, these non-physician health thyroid coaches, whatever they are. I can cure Hashimoto's. Well, here's the deal. If somebody has one of these stress-related causes of hypothyroidism, and you put them on the medication, and then you turn around and you handle their stress. You get them to stop over-exercising, or you get them to do some exercise. You get them to improve their diet. You get them to meditate. You get them to stop thinking catastrophic thoughts all the time. Reducing their perception of their stress, you may be able to taper them completely off these meds. This is one of the reasons why it's generally not recommended to slam somebody's TSH down into the cellar, because you do not want their thyroid gland to atrophy. You do not want that. And sometimes you can get them completely off. Sometimes you're just like, okay, let's take the dose down and down and down and see how we do. Anyway, that's all I've got for today. This has been really fun and interesting. I hope you guys liked it. If you have questions for me, please feel free to email me, drgibbs@danagibbsmd.com, or you can check out my website, danagibbsmd.com. And I do accept new patients now. Patients can find me on my website and get a discovery call to see if they think that I am the right doctor for them. So if you have more questions about this specific protocol, or you have a patient you want to discuss with me, get in touch. I'd love to talk. I'd love to help people figure this stuff out. And it really, really can make a remarkable difference in your patients' lives. All right, that's all I've got. Thank you guys for your attention, and I will talk to you again soon. Take care. Bye-bye.